recipients through the Erase Maternal Mortality Program, supporting maternal mortality review committees, or MMRCs, work in 31 states. By the end of September 2022, with the fiscal year 2022 omnibus appropriation, CDC anticipates adding approximately 8 additional state MMRCs. In addition, with this same appropriation, the CDC anticipates a new effort to directly fund tribal nations and regional tribally designated organizations representing over 100 tribes for engaging in formative work to define a tribally led MMRC approach. CDC is also working with the National Indian Health Board to support implementation of a tribally led MMRC. As of December 2021, 45 states and 3 cities with active MMRCs in the U.S. are using the Maternal Mortality Review Information Application, or MARIA, to guide their data collection and committee decisions, with almost 6,000 reviewed deaths entered into the MARIA system to date. For sudden unexpected infant death, or SUID, and sudden death in the young, that we just heard the panel speak about, in fiscal year 2021, the Division of Reproductive Health supported technical assistance to Navajo Nation for a SUID STY child death review. CDC supported provision of technical assistance on the child death review process and for the case registry's data collection system based on the National Fatality Review Case Reporting System we just discussed. CDC partnered with child death review programs that span Navajo Nation to create a roadmap of cases from death to review to case completion and prevention. Coordinating these activities included engaging law enforcement agencies and other stakeholders involved in creating the primary data sources necessary for a complete review of SUID and SDY cases. In November of 2021, CDC provided additional support to expand capacity building and technical assistance efforts to enhance the review of child deaths, with 35 death investigators from Navajo Nation trained in infant death scene investigation. Participants responded positively to the training, and the Navajo Nation requested additional trainings for their investigators in the future. With the FY22 Omnibus appropriation through a partnership cooperative agreement, CDC plans to expand support to 10 to 15 jurisdictions who are not currently funded through the SUID SDY case registry. CDC is also increasing support to development of trainings and best practice guides for death investigation and other materials for strengthening systems. Additional funds will be used for the system enhancements of the case reporting system designed to support case registry awardees and others conducting surveillance. CDC will also issue a new Notice of Funding Opportunity in fiscal year 2023 for a cooperative agreement to expand the case registry by increasing the number of awardee jurisdictions receiving support for SUID SDY surveillance programs. Additionally, case registry applicants will be able to apply for a new component of the cooperative agreement in which awardees will develop and implement data-informed SUID prevention strategies that address the drivers of disparities in disproportionately impacted communities. Finally, for CDC surveillance, 5 Pregnancy Risk Assessment Monitoring System, or PRAMS, sites completed activities to support tribes in the last 9 months, including, for example, Montana PRAMS, that updated a data dashboard to include American Indian and Alaska Native population estimates for a number of the indicators. Montana PRAMS also held a steering committee meeting, which included updates, discussions, and decisions on an American Indian Alaska Native sampling plan for the survey year 2022, American Indian and Alaska Native planned outreach activities, and a phone prompt experiment, which included American Indian and Alaska Native subgroup analyses. And finally, a summary of a project from last summer that looked at driving factors of American Indian and Alaska Native response rates, particularly related to geography. As CDC's Division of Reproductive Health continues to provide support for maternal health activities among American Indian and Alaska Native populations, and plans to continue to build capacity and improve partnerships among tribes, tribal organizations, and tribal epidemiology centers. Thank you so much for the time to provide this update.
Thank you, Cheryl. That was very, very helpful. I appreciate it. Does anyone have any questions for Cheryl?
I did really appreciate the update. That is very, very, very helpful. Some really good activities going on. So thanks.
I'm not sure whether IHS, NIH, I know that we've got, I'm sorry, I'm not sure whether NIH or FDA are interested or OMH are interested in making a presentation. I'm holding off on IHS because I know that we're going to have them talking to us after the break. So anyone from the other agencies?
I'm also going to give another opportunity because after the IHS presentation, we will be having a longer discussion about that. So if any of the other ex officios, want to be thinking about what kind of role they're playing related to American Indian, Alaska Native communities related to some of these issues, that would be also another opportunity for them to share whatever they can at that point in time.
All right, Dr. Ellinger, I think that calls that.
All right. Well, I just had one, and I know Dr. Warren, Michael Warren is gone, but I remember back in the 80s when the USDA, to try to save money on formula and to started contracting with sole source for formula. It allowed the feds to save a lot of money and expand WIC. But the world has changed dramatically since then, and obviously the formula issue, because of the limited number of manufacturers that WIC is contracting with. I'm just wondering if there is, and with COVID talking about the exchange lines of supply lines and all of those things changing, if there's some conversation going on about kind of re-looking at how the feds interact with the formula manufacturers. And I would just, I was going to raise that with Dr. Warren, but I think now's the time to do some of those thinking, because the world is a little different now than it was in 1980, 85 when this was first put into place.
Dr. Warren is not on the line, but I do know that there are discussions around supply chain issues and sort of dependency on one specific or two specific small number of manufacturers or providers of products that are considered essential. I'm not sure the degree to which there is a specific team with a charge to come up with a solution to this particular problem. Generally, FDA or other organizations that are charged with this sort of responsibility try to develop a framework that would be used as a standard for making those determinations across the board so that it's not piecemeal. I would encourage the committee, if you have any recommendations or suggestions on this particular issue, and factors that should be considered in the importance of this issue for the population that you've been charged to address or speak to, that if you have recommendations to bring them up and articulate them, and we would be happy to forward them to the secretary as you see fit.
Thanks. Any questions from members for Lee or related to MCHB? Magda?
Actually, it's a question that goes to Charlene at CDC, and it's a segue into the conversation after the break. And also Dr. Warren's comment about listening to and having conversations with the National Indian Health Board. One of the things that I think will be helpful for us in SACIMM is to have some just brief introduction to what is the Indian Health Board, how is it different from the Indian Health Service. There's a landscape of partnerships, organizations, and investments. And so either now or when we move into the session or when we talk about the Indian Health Service, it'll be just very helpful to know who do you talk to, how our voice is heard, who represents whom, what is sovereign. And I just would appreciate a 30-second refresher on that so there's context.
We will do what we can to have that covered.
All right. Seeing no other hands up, let's take a break. I can certainly I need a break right now, so I hope others do too. So let's come back at 1:45 p.m. Eastern Daylight Time. Welcome back to everyone. Hope you were able to take advantage of here in the Midwest, a perfectly timed lunch break. or for those on the East Coast, sort of a late lunch break, or those on the West Coast, an early lunch break. Hope you had enough time for whatever you needed to do during that time. So welcome back. It was a great first opening session, or sessions. I know we've got a couple of new members who have joined us for this afternoon, and I would like to have them take some time to, well, actually, like I did with everybody else, take a minute, as I mentioned in my email last night, to introduce yourself with what it'll take to fill in the blank question. So Marie Ramos, welcome, and introduce yourself to the rest of the group.
Hello, my name is Marie Ramos. My pronouns are she, her, hers. I am a family physician and current president of New Hampshire Academy of Family Physicians, a mother and a wife, and am a passionate advocate for health equity and all spaces thereof. There was a question, I think, Ed, you asked in the email. What's one thing that I would like for that we could add to make healthcare and the healthcare delivery better? I think if we could, as a system, recognize the humanity of each person in our communities that we serve, we would go a very long way, recognizing the humanity in one another. So I will leave it at that.
Excellent, excellent. And Sharonda Thompson. Glad you're with us this afternoon.
Hello, how's everyone doing today? My name is Sharonda Thompson. Can you hear me?
Yes, go ahead.
Okay, great. My name is Sharonda Thompson. My pronouns are she and her. And I am a community advocate. I am here as the voice of the people to see what we can do. And what I would love to see is an elimination of all the racial disparities in healthcare. That would be my perfect ideal world if we could eliminate those.
Well, that was, so then the question was, what would it take to do that?
Ooh, what would it take?
It doesn't have to be expansive. Even just one little step.
The first step would be for me, I think, training, starting in college, to look at people as a whole and not as a race. Not going into it thinking, because I know there are some things that are already in place that aren't factual, like, African Americans have a high tolerance in pain. So if they are complaining about pain, oh, it's okay, they can just deal with it. Well, that's not true. That's not true. So if we can eliminate those starting off while they're in school, maybe listening to real life stories while they're still in school and still training, and listening to community while they're still training, it could possibly help once they're out and they're doctors on their own.
Excellent. Good. Well, glad you're here. And I hope we hear your voice during our conversations along with everybody else's voice. It's important to have everybody contribute. And this afternoon, we're going to basically have two things. One, we're going to be focusing on the Indian Health Service, and then we're going to, in the latter part of the afternoon, focus on the recommendations that have been sent to everybody. But it was obvious that if you're going to be talking about the health of First Nations mothers and infants, we need to pay attention to what's going on with the Indian Health Service. And I mean, and I think you all know that we've been having some difficulty getting information from the Indian Health Service over the last several months. So we didn't have the right kind of information to really make some good basic recommendations related to the Indian Health Service. But fortunately, in the last 3 months, the Indian Health Services has appointed an MCH consultant, and that person is Tina Patara Lau. And she's going to be joining us, and had a conversation with her a week or so ago. Hello, Tina, glad you're here. And like I said, she's been here for 3 months. She's been in this position for 3 months. She'll explain a little bit more about how she's been working with the Indian Health Service in a clinical capacity for a much longer period of time. But she's assured us that she really is interested in working with this committee over the summer to come up with some, getting more of the questions answered that we have, and helping us, working with us as we develop some recommendations related to the Indian Health Service, since it is an important and critical part, but certainly not the only part of what we need to do with improving the health of Indigenous mothers and babies. So what we're going to do is we're going to have we'll spend some time finding out from Dr. Pattaralal what she's doing, some of her perspective, what she can share with us. We'll have some time for question and answers. And then we're going to, following that, we're going to just open it up for some general conversation about, with our federal partners and with members of this committee about how we want to, what questions do we need? What other additional information do we have? What do we want to know about what's going on? So we will have, so be formulating your questions and the things that you need to know. So first, let's turn it over to Dr. Pattaralal. Thank you for being with us, and I look forward to your comments.
Thank you, Ed. Good morning, good afternoon, and thank you to Dr. Ellinger and Palacios and your committee for inviting me to introduce myself and be present today. I also want to recognize two of our senior leadership who are on with us, Dr. Loretta Christensen, our Chief Medical Officer, and Ms. Elizabeth Carr, who is our Senior Advisor to the Director for IHS. So thank you for your presence as well. My name is Tina Pattaralal. I'm the new maternal child health consultant for the Indian Health Service. I'm an OBGYN. I've been practicing at Phoenix Indian Medical Center, or PIMC, and flying to both Parker and Peach Springs here in Arizona for the last 7 years. Currently, I'm sitting on Druid tribal land. Also a wife and a mother of 2 very active boys. I commissioned into the Public Health Service in 2007, completed medical school at the Uniformed Service University in Bethesda. Did my OB-GYN training at the Naval Hospital San Diego before joining the IHS. As I previously shared, my first year as an intern, I was actually trained by midwives, including low intervention birth and centering models. I'm glad to see this model of collaborative practice is reflected in the IHS as well. I'm honored to serve and represent the many Native people I've cared for and worked alongside. I speak from my experience as an OB-GYN in both urban IHS hospitals and rural clinics. It was actually a month ago I was caring for patients on a daily basis. And as one patient shared with me on my last week, you're the only provider I have seen consistently through the highs and the lows of my pregnancies. We will let you go as long as you go forward and speak our truth. I'm very familiar with the challenges facing IHS facilities in similar rural or underserved communities. I appreciate that the needs of our patients are complex, reflecting both traumatic and resilient histories. Providing care in the IHS is not as simple as writing a prescription or performing a surgery. It is earning mutual trust so that I may learn about personal family history, traditions, access to clean water, shelter, food, health literacy, racism, discrimination, historical trauma, mental health, addiction, and intimate partner violence. These and other social determinants of health affect access to quality health care across generations. To provide this comprehensive level of care takes a multidisciplinary team approach, including community health outreach and cultural support. My hope is that our team can grow the MCH program to provide a standard, readily accessible set of resources in collaboration with healthcare and tribal partners to help our site succeed. There are many stories of dedicated Native and Native ally individuals who choose to serve in IHS. I intend to speak for their needs and highlight their best practices. Looking forward, we share a common goal. We want to utilize the resources of the government for all Native patients, those who receive care in the IHS, tribal facilities, or the private sector. I appreciate the committee's trust and patience as I learn this new role and the national landscape. I'm here to listen, learn, and work with you to provide what you need to make well-informed recommendations. And thank you for advocating for our Native patients. Briefly, Drs. Ellinger and Palacios did brief me last week on the status of the committee, including your time-sensitive recommendations to the Secretary. I understand I may not have all the information you may need in the short time I've been in this role. And I've asked our senior leadership as well to be present and hopefully fill in any gaps. Dr. Ellinger, I did compile some comments on the recommendations that I will pass on to you after this session. Please let me know if it is most helpful for me to proceed with the brief overview or if there are any comments at this time.
Why don't you start with a brief overview, and then when you're done, I was wondering if we could, if the organizers of this could pin you and Dr. Christensen and Elizabeth Carr on the screen, so we could actually have a conversation with the three of you, so that, you know, as the questions could get answered by you or the other members of your senior leadership team. But why don't you go ahead with your comments first?
Of course. So I wanted to start just with a very brief overview of IHS as well as the structure before I take steps into what we know about our maternal care delivery model and our best practices, as well as areas that we could use some help and improvement. So first, the IHS is an agency in the U.S. Department of Health and Human Services. It's responsible for providing federal health services to American Indian Alaska Natives based on treaty obligations and rights. Established circa 1955 and funded via appropriations from Congress. Our mission is to raise the physical, mental, and social and spiritual health of Native Americans to the highest level. Service population, approximately 2.5 million of the nation's 5.2 million Native Americans who belong to 574 federally recognized tribes in 37 states. The structure of the IHS is divided into headquarters as well as 12 service units that I'll talk some more about. But healthcare, the headquarters level is responsible for setting policy, ensuring delivery of quality, comprehensive health services, advocating for the needs and concerns of American Indians, Alaska Natives. The 12 area offices then is responsible for distributing funds to the facilities, monitoring operations, providing guidance and technical assistance. Within this system, there are really three healthcare delivery systems. And I, again, do ask Dr. Christensen or Ms. Carr to chime in to help me explain further for the committee. But the first is the federal system, which is where I come from. It's funded by appropriations from Congress, consists of 26 hospitals, which we'll talk about as we move towards our delivery sites, and range in size from 4 to 133 beds. Average age of facilities is about 36 years. The second healthcare delivery system is the tribal health programs, or 638 programs, as you will hear. They're operated by tribes or tribal organizations who assume full responsibility for healthcare, formally offered by the federal government per the Indian Self-Determination Education Assistance Act in 1975. And these tribes operate with full sovereignty. Consists of 19 hospitals. And I believe there was a question from Magda on a prior discussion regarding what is the role of the National Indian Health Board. And so they actually represent tribal governments, both self-governing and those receiving care through IHS. They provide advocacy, policy. They actually have an advice to Congress, IHS, and other federal agencies. The third healthcare delivery system is the Urban Indian Health Centers, established around 1976. It's estimated approximately 78% of Native Americans live in urban areas. The IHS then enters into limited competitive contracts and grants with these 41 urban-centered nonprofit organizations to provide healthcare services. And the programs themselves define their scope of services based on the needs of their community. So each urban health center will be unique in that sense. Another comment I wanted to make, as of 2019, total number of IHS employees, I know this was one of the committee's questions, was around 15,000, approximately 2,300 nurses, 770 physicians, 800 pharmacists, 270 dentists. And we have a rough estimate that approximately 70% of our workforce is Native American. I mentioned the 12 IHS areas previously, so 7 of those areas do provide planned birth services. The volume, of course, will vary by the site, upwards of 50 to about 1,500 births annually. 9 of those sites are federal, 13 are tribal. Some data, now this comes from CDC, but we have discussed, and I've heard on this committee before, American Indian, Native American, and Alaska Native, I apologize, women are 2 to 4 times more likely to suffer pregnancy-related mortality than their white non-Hispanic counterparts. And they're twice as likely to report late prenatal care or no prenatal care, which is approximately 12% of births. Infant mortality is 26% higher in the national rate, and they are 3 times more likely in the overall population to have diabetes. When there's significant trauma that's affected a community, we see worse health outcomes over generations beyond those events. We see now in our Native youth, they are inheriting this trauma, but they may not have the same cultural resources and teaching for healing that the elders might. And that is the goal of our urban health centers. In the IHS, we have tried to keep track of our own birth data using a combination of information from annual facility reports of newborn admissions and the National Vital Statistics report. So this is very raw estimates that we use to help understand what our numbers look like. I want to add that the National Vital Statistics report uses a single race identifier, which we estimate may undercount Native births by 25% or more. So using those numbers, approximately less than 20% of Native births occur at IHS and tribal facilities across the US. Less than 10% of those births occur at IHS federal facilities. And we know that Native births occur in all 50 states, including the District of Columbia. And only 7 of those states have IHS federal or tribal facilities. So we would advocate for combined approach that to address health disparities, it is important to address all national health systems providing care to Native people. Systemic racism affects birthing safely nationally. Rural and urban health disparities affect rural people, including Indigenous people living in rural areas. We would also advocate that the National Vital Statistics address the policy implications of electing a single race versus a multiple race identifier and provide ready access to multiple race identified data. As mentioned in one of the prior discussions, there are also tribal epicenters and tribal PRAMs or pregnancy risk assessment monitoring systems that also have data on pregnancies. I'll continue now just to highlight some of IHS best practices, both from my time as a provider, and this is not inclusive, but we have, the CMO has advocated to have AIM bundles as verified by Acog and promoted across IHS hospitals that perform planned births. We have achieved baby-friendly hospital designation at all facilities that perform planned births. And this helps promote breastfeeding as well as education for the mothers. We do have a midwifery collaborative practice. I believe there was a question in the chat about how many midwives are employed. As of 2019, that number is about 84 positions across 5 of the IHS sites. And it really is a collaborative practice. I speak as a physician who, works with the midwife to ultimately offer the best care model for the patient. And in traditional cultural practice, the woman is usually attended to by multiple family members, providers as well. And so I can allow a midwife, or not allow, but I can rest assured that a midwife can work in our practice together and provide patient with the care that she is most comfortable with, especially for routine low risk birthing situations. And if I ever needed assistance, some midwives are even trained to first assist and can go back to the operating room with me, thereby allowing me and the midwife to work at the highest levels of our education. MMRCs, which I know that the committee has discussed, do often include IHS and tribal clinicians and tribal members. We would again advocate to continue to recruit Native voices for this initiative. We did start a pilot project for obstetric readiness in the emergency room to help address basically to address obstetric emergencies that might present in a rural setting. So we formed a multidisciplinary team, including our obstetric nurses, pediatricians, ER providers, and did simulation training using Acog's model on precipitous delivery, postpartum hemorrhage, and hypertensive emergency for over 100 providers over at PIMC. This helped increase their confidence levels and familiarity with the equipment, resulting in safe triage, stabilization, transfer of over 200 patients. In addition, we've incorporated during COVID a telehealth model into our prenatal care practices. This year, we actually are rolled out a trauma-informed care training to be taken by all of our staff. And finally, another program that was near to us at PIMC was the White Feather program for those patients who had a fetal loss. were seen on labor and delivery. This was started by one of our Native elders who is an obstetric nurse, and she actually put together a very culturally sensitive program on how to address that loss with the family, but then also what practices and questions should be in place. Finally, just speaking to the MCH program, I understand there are many areas of need, and I just, in my mind, can separate them into the acute and the long-term. The acute needs would, of course, be things like staffing and facilities, and so that's something that I think most of the frontline staff on the ground would benefit from. Long-term, I hope to grow the MCH program with the goal of being the support for patient, staff, and the sites to grow and expand on the obstetric readiness and ER program for rural areas, not just in IHS, but this does affect other departments, including, for example, our partners at the VA. The VA also has a model using maternity care coordinators, or 1 or 2 nurses for each division or site that would help, because again, patients are transferred out throughout their pregnancy or perhaps move to a higher level of care. These coordinators would help then follow pregnant women during the pregnancy to ensure they're accessing the resources they need to stay healthy, but then also capturing any significant social determinants of health and getting those resources on board, any high-risk medical conditions, diabetes, hypertension, and then most importantly, postpartum, making sure that they have access to the care they need, potentially home visits to take a look at the environment that the family is returning to, the sleeping arrangements, as you did mention in your previous talks as well. And lastly, really leveraging our academic partnerships. We do have a need in our recruitment and retention for staff. There's, as you know, in the United States, a wave of an advocacy for provider wellness. I speak very strongly to that because it does affect many providers, not just in IHS, but in other communities. And so we do have challenges with our recruitment retention that we could continue to improve. We do have a model through the Uniform Service University, of which I'm an alumni, is now sponsoring 5 IHS students per year who will then enter a commitment to service in IHS after graduation from residency. So in addition to that, I realized the need for being able to collect and hopefully provide more concrete data to help guide not only our initiatives, but I do believe that we can then use this data to help inform our decisions and our policies, to help make our own best practice recommendations as well on behalf of our patients. Briefly, my last comment, Dr. Ellinger, unless you have additional topics, was just to touch on the Acog contract. That's okay. So this is a partnership that has existed between IHS and Acog since 1970 for Acog then to provide professional support to colleagues providing women's health care to American Indian, Alaska Native populations, and to serve as a liaison and a source of consultation. This relationship as a provider in the field has been very mutually beneficial from my point of view. Acog has been able to do several things that I think have really elevated the care that we deliver. First, they do site visits for quality benchmarking, in which they tour the facilities, talk to our staff, interview tribal members, do HIPAA compliant chart reviews, look at policies, facilities, and then evaluate these based on and make recommendations based on Acog and IHS standards. These reports are peer reviewed and given to the sites, the local leaders, and the director of IHS as a summary of best practices and findings. Second, they do provide an Acog IHS postgraduate course every 1 or 2 years that focuses on needs specific to the Native population, mental health, substance use disorder, intimate partner violence, but also trainings such as also an NRP, which are required by our sites. Indigenous Women's Health Conference takes place every 2 years. The last one was virtually in 2022. Also focusing on cultural issues, mental health, trauma, depression. There is a focus, as I mentioned as well, maternity care in rural hospitals, which I am also very passionate about. Lastly, as I mentioned, the AIM bundle implementation and then implementing screenings for cervical cancer, diabetes, opioid use. They are fierce patient advocates as well of IHS. One of their recommendations back in 2020 was actually to fill the position that I'm currently in, which is to have an IHS maternal health consultant to help be that point person with other agencies and to be the subject matter expert here for IHS. So I'm quite honored to fill that role. Those were the points that I had. I would defer to Dr. Christensen, Ms. Carr, if you have anything else to add, and of course to the committee if you have questions for me. And thank you again for your time.
Thank you, Dr. Patarlau. And before we open up for questions, I do wonder if Dr. Christensen or Ms. Carr would have some comments that they could add, and then we can open up for general questions if they have something that they would like to add to what you already presented.
Yeah, so this is Dr. Christensen. Thank you so much. Thank you, Dr. Patarlau. Just a few little additions. She did a wonderful job in that summary. We do have some, as you well know, there are multiple maternal child health programs going along through the White House, through HHS, and through multiple other agencies. So we've had the chance to really look at what we do in our agency that I think supports everything that we provide for our moms and our newborns. And one of the things we're heavily involved in with the Federal Hypertension Group is monitoring, self-monitoring blood pressure in our pregnant persons. So we have deployed over 800 blood pressure monitors out into the field, into the pilot sites, to have these moms or pregnant persons monitor their blood pressure. As we know, self-monitoring is actually more accurate and more beneficial to the patient. So that is something we've done to look at and provide, prevent any preeclampsia or any issues like that very early. I think when you look at our morbidity and mortality, when we have broken it down, certainly all of us on this call want the very little or no morbidity or mortality. But when we really look what we're doing, it really wasn't any medical failures within our system with our pregnant persons. It was the social issues. It was the homelessness. It was the lack of social services. It was a lack of support, childcare, other things that kept people from getting the care that they should have gotten. So when we really broke it down, I mean, that's still very serious to us that this has to be mitigated, but we were happy to see that on the medical side of things, we were actually operating very well. And we did not have a lot of morbidities and mortalities that we could go back and say it was the way we provide OBGYN care. However, we do have to look at that social milieu. How do we get all of our moms into prenatal care? How do we get them all the way through prenatal care? And it is quite challenging in rural areas in Indian country because there is that right to come to appointments or take that telehealth call or not. And we are trying to really educate our moms and our moms-to-be on how important that is for us to always be able to monitor them so we could step in very early and avoid morbidities and have a good birth. We also we'd be remiss in not looking at the health of our pregnant persons before pregnancy. We all know that the health outcomes and lifestyles of our patients have a great impact on how healthy the pregnancy is going to be and how healthy the baby will be as well. So we can't just start when they're pregnant. We know we have to start before that, improving food insecurity, improving lifestyle, decreasing obesity, looking for early signs of diabetes before we address it during pregnancy. So that is all very important that we're looking at this whole lifestyle span. The other thing I wanted to add, because to make sure that we're all very clear on this, we work very well with our tribal communities and urban sites. However, them being sovereign nations, they do not have to share data with us. Some will share data because we work together, which is great. And we'd love to look at all our data for Indigenous populations very closely. But these are all each tribe owns its own data. So in collaborative manners, we can actually try to continue to work with them for more robust data sets. We can certainly do our own Indian Health Service data, and we're happy to do that because we want to measure where we are, but we cannot provide compacted or contracted data unless the tribe consents to that. We're working very hard at the headquarters level to make this more robust along our techs, our trauma epidemiology centers. We're creating more data sets for them. We are increasing the amount of data they can request. And I'm hopeful to this group will get more of the data that can really give us a good picture of what's going out across Indian country so that we can have a more robust discussion about how we're managing maternal health. So just wanted you to know that. And a lot of the, I know there was a question about NIHB earlier. These are all independent tribal organizations that work to put forth the policies and the needs of our tribal communities. They are independent. We do get invited to their meetings. We do report, we do talk, but they are definitely independent tribal organizations as well. And they're typically policy type of services that they provide to the tribal communities. So I just wanted to maybe fix a little bit of that information so you understand the milieu in which we work in. You know, certainly happy to answer any other specific questions. Thank you so much.
Yeah, Dr. Christensen, thank you very much. You did mention one thing that I think would be helpful to clarify: contract and compact relationships in IHS. So could you explain the difference between contract and compact and other hospital care, and also how your relationship with Medicaid?
Okay, well, first of all, and under the ISDA, under the self-governance type of contracts, there is a contract which we call Title I, where they will take specific programs. So they could say, just take behavioral health, or they could just take the public health nursing, and they would manage that. They would get all the money and resources to manage that particular service. So we have a lot of those contracts, Title I contracts across the country. Most of the hospital stuff won't be in there. It's hard to break the hospitals apart. Some do, but it's more your outpatient services, behavioral health and social services and things like that. And so they can contract for those specific services. Where we go to our Title V compacts, they take the whole thing. They come in and say, we want this service unit. We think we can manage it. They go through the whole process. It's vetted, it's looked at, it goes through the thing. And then we say, here's the keys. They take the building, the staffing, the money to support those programs, plus some other calculations that are fairly complex to make sure that we're handing over everything they need to be successful. It is our hope and our goal to make them successful as self-governing entities. So for example, if you took over X hospital, I would take everything, all the services, including L&D, you know, surgery if it was there, the emergency department, everything. And I would begin running that hospital now as a tribal organization. So, and they're set up in different ways, by the way, but that's basically the difference. One is more taking single programs, and the other is taking all of the programs at a specific site. And I know you had one more question. I'm sorry.
How the Indian Health Service relates to Medicaid, because a lot of funding for maternal and child health comes out of Medicaid, and I'm assuming with the Affordable Care Act, you know, with no copays and special set-asides for American Indians and Alaska Natives. Explain how that works.
Yes, of course. Our funding is a little bit different. We do participate with, of course, Medicaid, Medicare, and we have a good relationship with CMS overall. Quite frankly, in pregnant persons, almost the vast majority are qualified for Medicaid and will be enrolled immediately. So they will have that in place when they are going through their pregnancy. And then we have well over 90%, 90 to 95% of our pediatric patients, or the newborns on up, will also be in Medicaid, and they take, you know, get great support from those programs. As you well know, the Indian Health Service, we're self-funded as far as we're appropriated for the work that we do, and our rates are determined differently by CMS. But if they have third party like Medicaid, we of course submit that bill to Medicaid. We get our payment actually rather quickly, so they're very good with us, their turnaround time. And then for those few percent that might not qualify for Medicaid, the Indian Health Service will cover all of those costs. So there is no time that a pregnant person should not be supported with healthcare services, even if they're sent to a facility 100 or 200 miles away. We use what we call our purchase referred care funding, which we are again appropriated through Congress for every year, a certain amount, and a certain amount goes to each facility. And I refer that patient out and sign that off to them. They get full care wherever they go, whether it's high risk pregnancy, anticipated difficult delivery, or neonatal care for the baby should there be any issues. It is all covered by IHS funding through that program.
All right, thank you. I've got lots of questions, but I'm going to ask other committee members if they have some questions. Dr. Ramos.
Thank you. Thank you for the presentation. I have two specific questions. One I put in the chat. Dr. Patara Lau, there was mention of incorporation of certified midwives with maternity care. Can you share a little bit of how family physicians are incorporated within maternity care structure and framework as well, considering they also help support, particularly in rural health management? And then my second question was, what has been your level of exposure or experience in supporting those who identify as two-spirited in their gender identity, and how has that been incorporated within gender affirming care in this light?
Thank you for your questions, Dr. Ramos. The first is that, yes, we do have a number of midwives who do support and work in collaboration with us. I personally have training practice in working with family medicine specialists, including those who are fellowship trained in performing C-sections, and find their expertise in this and help to be very valuable. And so I do have experience in training. I have not at PIMC specifically. I'm hoping that Dr. Christensen or Dr. Carr or Ms. Carr can also speak to that as well. And then in regards to your second question with individuals identifying as two-spirit, I strongly believe that our verbiage is very important as well. And so I do apologize. We should refer to all pregnant individuals as pregnant persons. And I think that's my first step personally, is starting there with the language that I use. And in my practice, when I do speak to a patient, I always say, I ask and I never assume. What is your gender identity? What pronouns would you like me to use? What are your relationships with male, female, or both? And I do believe that we start by changing our awareness, we change our language, and then of course, using that education across our division. For example, Rick Haverkate is an individual who I recently had the honor of listening to, and is a director of the HIV and hepatitis clinics, and he himself has been a fierce advocate for the community, and just listening to his talk helped educate me. So I'm hoping his webinars that he has coming up, especially for Pride Month, will continue to educate our population as well. Thank you for the questions.
If I can just jump in, Dr. Ramos, to just build off of that, yeah, we're very supportive of our LGBTQ two-spirit. It is a very strong force in IHS. We are working on ways to support in many different ways. We are going to be beginning to ask those pertinent questions as part of the permanent record, so that we can definitely address people appropriately and deal with them in a way that is sensitive and responsive to their needs. So this is a priority for us, and it's something we all watch very carefully, and we try to educate constantly, because it is some change for some people, and we want to give them that opportunity to transition with us as we become so inclusive that it won't matter anymore, you know, so that it is just normal. So that is something that is actually very important to us, and something we participate again in multi-agency calls about how we do this, how do we support this along our way. We do have some clinics for our LGBTQ patients that is specific to their needs and addressing any kind of gender affirming type of actions that should go forward. And we're very proud of those clinics, and we hope to expand more of them across the agency as we move forward.
Thank you. Dr. Palacios.
Thank you, Dr. Patara for joining us today and sharing. And then thank you for Elizabeth Carr and Loretta Christensen for being here as well to help answer some additional questions. I have two questions, one regarding funding and the second regarding data. So the first question I have regarding funding, I want the committee to really understand that because of treaties that were made with Indigenous sovereign nations, the US government has a federal responsibility to provide services, and health service is one of those services. And please, speak a little bit about, it was mentioned that the funding mechanism by which Indian Health Service is funded is through congressional appropriations. And what I understand is that varies year to year, which we heard. And can this funding be cut before it goes into Indian Health Service hands? Can this funding be sequestered?
So, I'm sorry, did you want to ask both questions or do you want me to jump in?
So for the first question for data is like, yes, for not data, for the funding, but before the money is dispersed to Indian Health Service, is it possible for the funding to be cut, to be sequestered?
Anytime there's appropriated money, though, that has always been a possibility. What we're looking forward to is we have worked extremely hard to work towards mandatory funding, which would then not allow any sequestering of that funding, because that is deleterious to us, quite frankly, and very stressful. Yeah. So we are working towards achieving the mandatory funding, which would then allow us to not ever be shut down, allow us to not be sequestered, et cetera. So this has been a long battle, as you probably know, and it's something that we believe in very, very much. And so we have crafted budgets that we feel, and they're probably still not enough, I'm going to say that, but they're way more than we've ever gotten. And that is an encouraging step. I'm going to call it a step. That we have asked for a lot more funding. We did get more funding this year, which we are sending out in whatever way it is indicated for, such as the water access projects, the SFC. Huge amount of money is going out to Indian country to make sure everybody has running water and access, and to waste disposal and et cetera. So that is a huge step for us. Could the funding, well, technically, yes, if it's appropriated funding, it could be cut. That's why we're asking for mandatory funding. It is very, very hard to plan ahead when you don't know what you're going to have. So that is extremely important to us as the Indian Health Service. And I see Ms. Carr is on, so I'm going to kick it over to her for additional comments about that.
Thank you, Dr. C. Yeah, I was just going to mention that, this year the administration did propose a mandatory budget proposal for the first time in history, which is a really significant step forward. Of course, Congress has to act on that. And that's where our tribal organizations come into play. They do a lot of advocacy on behalf of Indian country and IHS. On the Hill, because as a federal agency, obviously we can't do that. And so that's the role that the National Indian Health Board, the National Council of Urban Indian Health, National Congress of American Indians, and others, other organizations such as those do on our behalf. So I just wanted to kind of add that extra piece there, because I know that there was a question earlier about the role that NIHB plays in this space. So thanks.
Thank you for those answers. So I just want the committee to really understand that there is funding, it's appropriated by Congress, and it can vary year to year. And only most recently have we even come close to the actual funding that is needed, right? That's not really ever happened in our history through Indian Health Service, that they haven't been adequately funded. And as Dr. Lau shared with us that, what was it, like the average age of the facilities are 30 plus years of age. So we have an aging infrastructure that Indian Health Service is working with, trying to deliver care in addition to this. So then this next question is related to data. What I heard also was that, and from Dr. Lau's presentation and from what Dr. Christensen has said, that Native American population in general can be a very complex population to serve because of all the different social determinants of health that have, without access to clean water or waste management, without access to electricity, so just as a baseline, in addition to facing institutional racism or systemic structural racism and poverty, incarceration, all those things. So when we talk about hypertension, someone in a pregnant person, and IHS being able to give out 800 blood pressure cuffs to monitor for hypertension, of course, the OB provider is not at fault for that person developing preeclampsia. What's at fault is the milieu that people are living, like this historical legacy that people have inherited. It sounds like definitely there is data that Dr. Christensen was able to foreshadow a little bit by looking at maternal morbidity, that it wasn't any kind of IHS service provision that was a factor for someone developing preeclampsia, right? It was the social milieu. So with this data that was discussed just very briefly about, it seems to me that despite the obstacles that are inherent in working with a small population of people, that there would be ways to communicate to this committee and to the general public that the needs of this population are very great, possibly greater than what we have even ever been told, and that there are possibly very wide regional differences. And are there any movements in trying to be, I mean, I understand that you're working with National Vital Statistics and other avenues of trying to look at this small number data and possibly looking over periods of time to collectively aggregate, but what are the mechanisms that would fast track this data to be shared? Or what kind of education could be given to tribal communities if consent is needed to aggregate information that would enable the committee here to understand just how grave the maternal morbidity and mortality really could be?
Yeah, okay, thank you for that question. I have two different answers that are both very important. Number one, what can we do? Well, one of the things we've worked very hard on since I arrived at headquarters is looking at the social determinants of health. It is very easy to say we have them because we have them all, and we've had them all for a long time. So that doesn't help very much to me. So we're looking at it in a different way. How do we quantify? How do we actually identify what we're dealing with? And what is a relationship to what we're dealing with in SDOH that it forms the risk that each person is under? So our next step of our project, we've defined a lot of SDOH. We have a great team that's working on this, is we need to start asking those questions. So our goal is that we'll be getting that into the electronic health record where all these SDOH domains will be questioned to each patient. It will be put in the system and applied a risk matrix to it to see who are our highest risk patients. So to answer your question, if we have that data and we went back and we pulled all pregnant persons and we look at that, we could see the tiers of risk and where we might have missed something, where we will need to interject something ahead of time. But without data, without quantifiable data, it is very hard to make a plan to mitigate, as you alluded to. And in each one of our areas, the actual SDOH will be different for each area because some will have more transportation problems, some will have increased food insecurity, some will, like you said, no running water. Alaska, part of Great Plains in Alaska, very prominent in those areas, and even some problems in California lately with water, maintaining water plants and such due to severe weather issues that have been going on there. So that is a step that we can start to get some data out of to say, this is what we're seeing, this is what's causing poor health, poor outcomes, and impacting the lives of our American Indian, Alaska Native people. So that is one big project that's rolling out that we will have in our system. And then we will have a heads up, this patient really needs to be tracked more than this patient, although they all deserve and need attention. This one is our high risk patient. And we can certainly do that for our pregnant person population. And we have to do it before they're pregnant. As I said, we have to be looking at what's the health of the possible pregnancy ages that we have in our communities to make sure they're getting all that ahead of time. Good food, exercise, make sure they're not diabetic, make sure that they have healing food, etc. like that. We can be very proactive in that. And that would be the goal, is how do we get a healthier population so when they are pregnant, it is a more healthy and a better pregnancy. So that's my first answer. So that's one way we can gather data. The second way I would look at gathering data is we have some really excellent texts, epidemiology centers, and I don't think they have been fully actualized, if you will. I think by working with them, getting the data that they need to do some analysis in their own communities, because they know their communities very, very well, we have a chance to get some very robust data that we can address in each of those communities. So I would highly encourage, we are trying to even provide additional data, make it easier for them to request data that we have, so that if they can process all that data as an aggregate for that population. But, with it, and of course, I don't mind working with tribal organizations at all. I have worked very well with them in Navajo. We shared a lot of data. I think COVID changed a lot of things for us. And we saw what happened when we worked together and shared data and mitigated and did things together. So I am encouraged that working forward, we can get that data you're talking about, but I do look to our texts, because I think they're a great asset And I would very much like to support their looking into our data and helping us plan and take care of our population better.
I have a couple of questions. Has IHS evaluated the outcomes of compact tribes, contracted services, and Indian Health Service run activities? Have you evaluated the effectiveness of those and found out things that work and don't work better than others?
Well, I wouldn't say we evaluated them because, you know, as I said, they're tribal, the tribal facilities are very sovereign. And if they want to share their data, we're happy to work with them for sure. But I think that when we look at outcomes overall, we can get some lessons from them. One of the things that the IHS has not been doing in the past, which we are working towards right now, is more participation in the maternal collaboratives. You know, we have certain, I don't know if you all know, we have certain privacy data restrictions on us that we can't just say, here's all our data. There is a process we have to go through that protects the personal health information of every one of our patients. Therefore, you have to work through some of those challenges, and we have found some alternative pathways to use more aggregated data to participate, because we want to hear best practices. We want to discuss our challenges. We want everyone at the table, tribal, urban, state, and IHS, to learn from each other and to enhance maternal healthcare. So we are looking at ways to do that, and we are highly now encouraging everyone to participate in these collaboratives in a way that we say Navajo area shows up and says, this is our data for Navajo area. This is where we have challenges. This is where we could do better. Same with Phoenix. Now they can't go down to the minute data because it's identifiable and it would violate our privacy laws. But in an aggregate, we can have a good conversation and we can see what's going on. And then when we come back internally, our staff needs to get together with all of our partners and say, okay, this was my problem in this facility. This is what I saw. We had, you know, no prenatal care. How did you guys get your people into prenatal care so that we could help our pregnant persons? And so I think that sharing of data and that group effort is going to be very key moving forward for maternal health. So we look forward to working with our tribal and urban partners. And that would be the goal, is for us all to work together. So I think we have a good chance at that, and hopefully our partners in the sovereign nations will work with us on this to make it better.
Good, thank you. Sticking with the evaluation question, has the Acog contract with IHS been evaluated?
You know, I don't personally oversee that. It was in existence before I arrived at headquarters, so I will have to follow up where we are with that, the status of that contract. No, I'm happy to do that. Okay,
good. And then I understand the care for Alaska Natives is, the organization of that is a bit different than it is for the American Indians in the other 49 states. Could you explain the difference and sort of the benefits or the pros and cons of the different kind of an approach?
Well, the Alaska area for us is all tribal. So we don't own any, the facilities are all tribally run through their consortiums. So they've developed oversight consortiums that do a really great job, actually really great job. And so they have adapted the care to their population, their challenges, the way they have to do healthcare in Alaska, which is quite daunting. You know, and just to give you a visual, they were moving vaccine by dog sleds. You know, they do what they have to get things where they do. And we're using helicopters to drop vaccine in the bottom of the Grand Canyon to get to our clinics down there. We're extremely adaptive in Indian country to get what needs to be done. And nobody knows better than those natives of Alaska that to run their own programs. And they've developed these workstations, and you know, they don't have formal clinics everywhere. It's not quite possible, but they have found other ways to train. They have the CHAP program for a long time where they train their community health aides who are excellent. They have that for dental and behavioral health, because those people in those communities are certified and educated to take care of their own communities, and they do a great job. So they have developed their own health system adaptive to their environment, adaptive to the personnel they have to do these jobs, and they've done it very well. So they're great. Their consortiums are very, very good, and they're very great advocates for care. And we do love having them at the table because they contribute a great deal to the overall care of American Indians and Alaska Natives.
Magda.
I'd like to defer, if I could, for what's in the chat, because I think that Dr. Ramos had a comment that it would be helpful to elevate and also to hear from Shira Rutman. So could we look at those two before I take my time? Because I don't want to miss their very strong comments. Dr. Ramos, is there anything you want to say about the comment you posted?
If it's referring to the last one, Magda, thank you. I'm familiar that with particularly Medicare Advantage plans, they're looking at incorporating community health workers for their most at-risk patient populations. And that reminded me of the World Health Organization's mitigation strategy for maternal care in utilizing educational services for community members to help support maternal care and prevention services in a hyper-local and a culturally appropriate way. And so I was wondering if similar models are being taken into consideration. If not, I think it would behoove our committee to consider such community health worker models to implement, particularly in reducing maternal morbidity, mortality, and infant mortality. There's actually and I put in a link from UPenn that shared a similar model for community health workers for particularly high utilizing Medicaid populations, and the return on investment of paying for 5 community health workers to work for the highest risk population within this Medicaid pool was 2.5 times fold, meaning that there was a spend of about $500,000 for these community health workers. Within a year's time, rendered $2.5 million in cost savings for these particular population group because of improvement of health. So it's something I think is not necessarily traditionally incentivized within our high-risk populations in the IHS for our NHSC medically underserved areas, but in thinking about creative models that we can implement and in a hyper-local manner, this could be another added recommendation.
I just want to make sure we heard that. And Shira, I'm going to build off of your comment about the tribal epidemiology centers. I just want to thank you for your comment that is there. And I was wondering if I've got 2 questions. One is, what is the relationship between the tribal epidemiology centers, which I really appreciate the comment about, we appreciate our texts and we would like to see them, utilize more and a greater sense of aggregating information between what comes from the electronic health record in the IHS system and what the tribal epidemiology centers can do. Appreciate that. CDC has funded an MCH epidemiology positions working with states and in cities. I recall that from my City Match days. Thank you, Dr. Bill Sappenfield and others that have invested in that and in previous times. So when we have epidemiologists funded and empowered with access to good data, good things can happen. So I'm wondering, can you talk more about what it would take for the tribal epidemiology centers, particularly with an MCH focus that Dr. Patera Lau might be able to lift up as she gets beyond her first trimester of being in her new position, and how to align the work of the MCH epidemiologists in the tribal epidemiology centers with the other MCH epidemiology work happening with the support of states and localities. So there can be an alignment of that influence, given that 70-some% of Indigenous folks wake in urban areas, at least off reservation. So I was just wondering who can speak to that potential, because that could be very concrete and stronger too if it were aligned with other investments that are going on to build the infrastructure for MCH epidemiology.
So I'll try to tackle this, but you're definitely pushing all the boundaries today. Yes, I mean, I think the techs are a very interesting entity, and quite frankly, there's been a lot of shifting in funding. So we're going to have to kind of see how some of that shakes out. I think that yes, could we look into more funding? Could we look towards specifically MCH? Of course, those could all be on the table and are all extraordinarily important. I think there are several goals, and again, I will not speak for the techs. They're tribal epidemiology centers for sure. But wouldn't it be great if everyone hooked up what they're doing and the data, and we're all kind of having the same goals of what we're collecting and what we're aggregating, so that we could actually see a true picture of what we're facing. I agree with that completely. I'm hoping that's the future. I know I've had some meetings with CDC. NIH and other agencies are, how do we get some common data? How do we work together? Not, not separately, all trying to pull data from places that we wear everybody out, but more like a very concerted effort to get meaningful data. Like, what can we use to impact outcomes? Not just that we have a lot of data. So I think that's all extremely important, and certainly something we would be interested in to look at our populations across. I think improving and increasing our relationships with the techs is vitally important. How can we support them? Again, my public health service teams came to me and said, we think that they could deal with more data. They've done a great job. They've used it well. We think they'll do fine with it, no problem. Do you think we could widen what they could ask for in data? And I said, yeah, we can definitely do that. That's the way we support them, is giving what they need to do what we also would like them to do, which is really look at their tribal communities and really be able to look at cancer data, MCH data, their SDOH type data, and those things that are very important to us as we plan. Because even as IHS, how do we plan? We look at what's going on in the Indian communities and our Native communities and say, what do we need to help with? What can we support? What do we have to provide technical advice over? What's our goals? And that's what we want, is that feedback too. So we know where to direct energy as well, so that we get what we need. So will take that back, certainly. And bring that up. I haven't been, I've not been at headquarters very long, so I'm still learning some things as well. And I have to go back to my team and say, what's the history of this? Where did we get stuck? What do we need to move forward? So I'm happy to do that. I also have good relationship with the other optives and looking at data as well. And I'm happy to have a group conversation with them as well, so that we can get more coordinated and really make an impact on outcomes. And then the community health worker statement. Thank you very much, Dr. Ramos. Yes, it is. Now, this may just be my personal thought, but it is my priority thought too, that we have to take more care out into the community. We can't possibly get everybody into our facilities. Is there enough access? Number one, do they have to travel too far? Definitely. Are there roads? Can anybody afford the gas anymore? Anything like that that would prohibit people from accessing care, we have to mitigate that. So we're pushing very hard to get everything back towards the communities. We just had a meeting on cancer care, prevention and treatment, screening in the communities, because that's the goal for our program. So yes, we are trying to expand our, we do use our CHRs, which are called community health representatives, which the tribes typically are, that's their staff. But we work very closely with them at our facilities. They do all the investigation for STIs. They do the health checks. We couldn't have gotten through the pandemic without them. Let me just say that. So I totally support that out there. And actually, we're advocating for non-traditional providers to be reimbursed for their care. And that would include community health workers, behavioral aides, peer-to-peer, dental, the dental assistants that are needed in some areas where there's no dental care. And it would include navigators. It would include a lot of things out in the community to help people access and get the appropriate care. So absolutely, that is a model that I'm looking forward to. Is even our public health nurses don't get reimbursed for their visits, and they do amazing work. Our pharmacists run a lot of our clinics. They do amazing work. I said, you got to look out of that box. We provide care with what we have in our communities. And if it's a community health worker, great. If it's this person, great. We need the care. We need someone out there touching base with the patients in their communities that know them, that speak the language if possible at all, and to check on them. Like, they know where every single person lives. I don't know where every single person lives in those communities, but they do. And even during the pandemic, that's how we vaccinated at home. They told us these 3,000 people can't leave their home. They don't have a ride. They're scared. They're sick. They're disabled. Fine. We sent all those vaccines out into the community and vaccinated them at home. That was our CHRs that helped us navigate that. So I am completely in support of that. And I look forward to that progressing as we move along.
Now, Dr. Patera-Lau and Dr. Christensen, when we arranged the schedule, we set you up for an hour, but this is a really good conversation. Would you be willing to stay a little bit longer to take a few more questions?
I could stay about 10 more minutes, and then I'm afraid I have to jump.
No, that would be excellent, because I think this is a good conversation, and I don't want to cut it short. So the more time you can give us, the better. So we'll add at least another 10 minutes. So thank you for that. Dr. Palacios.
Thank you. This is more a community voice kind of question for you, Dr. Christensen. And the community voice comes from having worked with people in the Phoenix area, and with the recent closure of the Phoenix Area Indian Hospital, the labor and delivery unit. And the community felt that there was not communication from Indian Health Service as to why this labor and delivery unit closed. So earlier you were sharing that that there is a sense that the community works very well with Indian Health Service, but I'm just wondering, would tribal communities say that they feel that way, that they feel that they are working well with Indian Health Service and that Indian Health Service is meeting their needs? Has there been a formal evaluation asking not just tribal community leaders in, like in a health director kind of position, but additional leaders from additional people from the community?
Well, I think that's a really great question. And if I have to say, the number one issue that almost is inherent across the country is communication. You do your best to communicate, and you invariably are missing people, for sure. I think that what's really important, and I know that it was, nothing's ever been perfect, for sure, but the pandemic really disrupted a lot of our normal ways that we communicate. We tried to adapt very well. I know that the closure at PIMC, I know it was put out in many different ways. It obviously didn't reach some people, or they felt they didn't understand why, or maybe not enough information. And I would love more feedback. I would absolutely love more feedback. I will tell you that, the way, due to regulation, that we can survey patients is very limited in the Indian Health Service. We have to go through quite an ordeal to get surveys approved that we can send out to the community. I would love that feedback. It's something we're working on, trying to, if you will, modernize that effort, because I would like to survey our own staff and say, what else, what do you need from us? What is not happening for you? Because remember, 70% of our staff is American Indian Alaska Native. So I need that input too. So I take your point, and I wish I could just do that right away, but it will take a little bit more concerted effort, which we're willing to do, for sure. The best way I've gotten feedback, and again, it's not ever always anybody, is when I was at the area service unit level, I had community town halls. Sometimes I'd get 3 people, sometimes I get 20, but I would ask them questions. How do you want me to communicate? What's the best way to tell you something? What do you think we're doing well? What do we need to do better? And you take a lot. They're not unhappy. They're not happy a lot of the time, but very valuable information is gathered from community input. And I do totally support that all of our service units take the time to do that. Not just the leaders from the community, but the people that are getting care. What they felt when they came into the facility, what they needed, what they would have wanted to happen, because we can't improve our system if we don't have that constant feedback. So we're looking for ways to do that, working on a patient experience survey, which will help us some, not all. And then we need to be very open to that feedback, because I don't think you can improve things unless you get that feedback. Because I could think I'm doing a great job, and if you come in and say, I hated this, you didn't do well at all, then I need to know why you think that. So I think that is the customer service side of what we need to work on. That is something that is very important to us, and something I hope to see improve over time. I will add that our new program in trauma-informed care, which is mandatory training for 100% of our staff, our volunteers and our contractors, is for them to understand trauma-informed care and address people accordingly. Because I think that it's easy to get in a habit of working and just getting people through the system. What they need to do is make that connection and make sure they're being respectful and sensitive to what people may be going through, maybe why they don't want to come into a facility. And certainly even our own staff, when we deal with our coworkers, are we being sensitive to what might trigger them, what they've been through, what they're carrying around while they're trying to provide care to someone else. So it is our goal to roll out this trauma-informed care and change the organization. It will not happen right away, but it will happen. And that way we are approaching things in a way that is so much more respectful and sensitive. And I think we can communicate much better that way. So we are definitely taking a very hard look at that. Thanks.
Thank you. Thank you for your comments, and thank you for being here. I know that this is, it's difficult being in a hot seat, and it's not really hot. I hope it was just a bit warm. And I want you all to know I really appreciate the work that you are doing, that everyone at IHS is doing. It is the concern is not necessarily the system of Indian Health Service. It's the parent, right? It's the way that it was set up. So my heart goes out to all Indian Health Service employees and Dr. Lau for being here and giving your compassion, and for staying in the long haul. I hope you all do. I have family members and friends who work with Indian Health Service, and I was a patient, and my family members are patients. This is more philosophical. You do not have to answer it. But the way that Indian Health Service was set up, was it set up to succeed, or was it set up to fail? And that's just something that I think about from time to time as we move forward, because certainly the funding issues and year to year not knowing if you're going to get your funding is a huge concern, because you have no idea what kind of programs you can do, let alone all the issues that we are having with data, with working on community relationships, and with really trying to improve Indian health in general when you have so many other factors at odds. Thank you for the work that you all do.
Thank you for your comments, Janelle. And before you leave, I just have one question to leave you with, to maybe you could help us out. We make recommendations to the Secretary of Health and Human Services about how to reduce infant mortality and reduce maternal mortality. And I know you can't tell us which recommendations we should put forward, but when I would hide Easter baskets for my kids, I would say, you may want to look in this direction, or you may want to look in that direction. Are there some guidelines or some directions you would like us to start looking that might be helpful, that might help you in terms of help us help you do the job that you're supposed to be doing? So do you have any clues on the direction we should be looking, the questions we should be asking, the people we should be talking to, so that we would come up with the right kind of information to form the best recommendations to the Secretary as possible?
Okay, well, that's a great question. I guess I'm going to just kind of frame this the following way. I've had a lot of these calls this week, by the way. I was on with the CMS Rural Health earlier today. Same type of questions came up. And I guess the first thing I'm just going to say right up front is I think a lot of agencies are using the term equity, and I'm going to look at equity slightly different. Equity implies we all started from the same spot, and we kind of all know that's not true. So how do we establish a true equity where we are on an equal footing to provide services in the best possible manner at every single site? And a lot of that would do with things that we can do is the diversity of our workforce. We need non-traditional be able to be reimbursed for non-traditional staff. You know, we had probably the most non-traditional vaccinators of anybody in this country during the pandemic. We trained everybody we could train to do it, and we got it done. Same thing with getting out in the communities. How can we support community health? How can we get those workers reimbursed? Not because we're going to make a lot of money out of it. It's not that at all. It's to support our systems and to be able to hire more people. You know, how are we going to get, you know, equal access to telehealth when we have broadband deficits in 40 to 50% of our communities? So can we get telephonic reimbursement? Because a phone call is better than nothing, for sure, that we can call and check on somebody. How are you doing? Read me your blood pressure numbers for the last 10 days, etc. So those are two big things that came up that are very, very important. And I think the third one, which is a much bigger project, is the expansion of our graduate medical education into tribal communities. We need to be able to get providers out there, show them what rural healthcare is like, and try to encourage them to become part of our services. But we can't do that unless we have some framework. So we've been working with both the VA through their 403 Mission Act and CMS to give us an alternate pathway to support graduate medical education and place residents in hard fought areas where we don't have a lot of providers, and also to train residents that are then very amenable to serving our tribal communities in an appropriate and cultural way, not just throwing them there, but making them part of those communities and part of the solution to those problems. So those are very important things when we're looking at healthcare and rural. And the last thing I'll just pitch out there is even the emergency EMS training out in the fields. You know, we're very far apart. We need to uptrain our EMS so when they respond, they're able to take care of some of our problems out in the rural areas. Certainly communicating back with the hospitals, but not having to always drag that patient all the way into the hospital for them to sit and wait for somebody to see them, and then they don't have a ride home. I think we need to take the care back out into the rural area and refine that care for our rural population. So those are just the tangential ways of me saying what I think would be helpful out in Indian country.
Thank you very much. Lee, you have your hand up.
Yeah, thank you, Dr. Ellinger. First, I'd like to thank Dr. Christensen, Dr. Patera Lau, and Ms. Carr for taking the time to be here with us. And to, as Janelle had said, sit in the hot seat, which hopefully wasn't too hot, but was just very intent on getting some answers. I know that for all of you, your tenure in these positions has not been that long. And I know that you, from personal experience working with IHS, that you find yourself in a lot of positions where there are competing expectations, competing demands, and you know, sometimes balancing the needs of maternal and infant health versus making arguments for funding for construction facilities and water and sanitation. They shouldn't be competing with each other, but they are for the scarce resource, which is your time. And so I appreciate that. I also appreciate the measured, thoughtful and insightful approach that you've taken to answering the questions for the committee. As a federal employee, I sat and cringed a couple of times wondering, how do you respond to questions when this is the agency that you're representing? And I think you've done a masterful job of that and showing that you and we are all committed to trying to improve the public's health here. What I'd like to put out there for future discussion, because I don't want you to feel that we are asking for something immediately from you, is, as Dr. Ellinger had said, there will be another meeting that we are planning on doing in September, focusing in on the recommendations that are going to be made. I know that IHS thinks about these issues regularly among the many other issues. And rather than coming up with your own personal recommendations, which some of them you've provided, but are there particular priorities that the agency is working towards when it comes to issues of delivery or issues of education or issues related to bundles in facilities that you would like to articulate for the committee, so that the committee can determine whether or not it wants to then say, we reinforce that, we will amplify that in our messages to the Secretary and to the Hill and to anyone else who would like to listen. So we will hopefully be able to continue this conversation between now and September. And if you have any thoughts, ideas, recommendations that come from the agency or from those that you work with, we can collect that, share with the committee for them to then use it in their deliberations in September.
Yeah, that reminds me that our plan is we're going to have a little work group, and I talked this over with Tina, Dr. Patera Lau, that she would be willing to meet with us during the summer to share whatever information she has with this smaller working group, so we can clarify where we're going, so that nobody's surprised that we're working we're rowing in the same direction. So I hope that we can do that over the next couple of months as we prepare for September. And Janelle, did you have one more comment? Or okay, so thank you, Dr. Patera Lau and Dr. Christensen, and what happened to Elizabeth? I think she's still on, but we really appreciate your time. We're going to have just sort of a general open discussion, and I'm hoping that we get some feedback from and some questions from our other federal partners about what they're doing with American Indians, Alaska Natives in the next half hour or so. So you're welcome to stay on and listen to that if you'd like. But I really do appreciate your coming here and responding to the questions. As like Lee said, you were very measured and straightforward and candid as much as you could be in those conversations and responses. So thank you very, very much. All right, so I want to take a look and see, are there any of our federal partners, our ex officio members, who may want to have some comments about what they heard and what it stimulates in their mind about how they are or should be interacting with the American Indian Alaska Native community from their perspective. So any thoughts from any of those?
Hi, Ed, this is Danielle.
Yes.
So one of the things I wanted to address that I have been hearing as a part of these talks today is how in many of the reviews of American Indian and Alaska Native data, we are using multiple race data and not just the single race data as given by OPM. And so I believe Dr. Patera Lau made the comment about the National Vital Statistics System, which is what group I'm a part of essentially, and the desire for multiple race data for AIAN. And I would just like to bring up that we do have that data available. It is in our data files, and it is actually available on our CDC Wonder website. And even going even further than that, if the group is interested in any statistics related to the birth files or the linked infant death files that I manage, we can provide some data on multiple race AIAN if that is requested.
Excellent, thank you. Any of our other federal partners?
Hey, this is Charlene. Just to echo what Danielle brought up, we are also considering the definition of race and ethnicity and looking at multiple race to disentangle how we can increase that number of American Indian Alaska Native members to our analyses when it comes to maternal mortality and other topics. So I think that's a really important point and a great presentation by an earlier panelist.
Thank you, Charlene. Anybody else from our federal partners?
Ed, I have some if you would like from HRSA.
I'd love it.
Okay, so these are updates that we had provided in support of our Tribal Affairs working group. We meet with tribal entities to update them periodically on the activities that we're doing around tribal groups. So I'll just run through them very quickly. HRSA's Healthy Start Eliminating Racial and Ethnic Disparities program improved health outcomes before, during, and after pregnancy, and reduced racial ethnic differences in the rates of infant deaths and adverse perinatal outcomes. The program awarded tribes and tribal organizations 2 grants totaling $2.3 million. These funds include a one-time supplement for $80,000 in funding to address infant health equity for one Healthy Start grantee that is a tribally designated organization, and that is the Great Plains Tribal Chairman's Health Board in Rapid City, South Dakota, and the Intertribal Council of Michigan in Sault Ste. Marie, Michigan. That looks like a couple different things. Anyways, it's the Intertribal Council. As we said, our McV program administered by HRSA and ACF, which funds the Voluntary Home Visiting Program, has a tribal home visiting program that is run out of ACF. It provides grants to AIAN tribes and consortia of tribes. It administers 23 5-year competitive awards to tribal entities at $12 million per year. In FY20, the home visiting served 3,315 parents and children, 1,606 families, and conducted 17,129 home visits. And MCHB awarded $10.7 million in ARP funding to 24 new pediatric mental health care access program award recipients, which included 2 tribal entities, the Chickasaw Nation in Ada, Oklahoma, and the Red Lake Band of the Chippewa Indians in Red Lake, Minnesota. The pediatric mental health care access program recipients were awarded up to $445,000 per year for 5 years to promote behavioral health integration into pediatric primary care. Healthy Start Technical Assistance Support Center continues to offer educational webinars, including strategies to strengthen health equity programs, fatherhood programs, and quality improvement. Between March through June 2022, the Healthy Start TA Center will offer educational webinars that are available for tribal entities, including Fatherhood Talk Tuesday, the Equity Table, Root Learning Academy, which is Restoring Our Own Through Transformation, a 2-party series focused on exploring structural and social determinants of health, Understanding Prenatal Alcohol Exposure and Preventing Fetal Alcohol Spectrum Disorder, and the Equity Table session, which focuses on fatherhood in the age of mass incarceration. Those cover most of the activities that we had reported to the Tribal Council.
Thank you, Lee. Maybe you could send that list to me and I can share it out with the committee so they know all of those activities going on.
Got it right here.
All right.
Ed, can I ask you a question? I really appreciate getting this update, Lee, and Charlene gave a lovely array as well. Is from an MCH specific to hopefully maternal infant mortality, but from an MCH investment between HRSA and CDC, or even is there any consolidated budget investment to look at it as tribal, or is it sort of within this there's tribal, within that there's tribal? I'm just trying to do some visual mapping about where the investments are going, given that there is not a mandated universal budget or universal investment, as we can also argue and support. I'm just trying to get it. It feels like it's scattershot from a big picture perspective and very strategic from an individual funding perspective. So how do you, when you go to the Tribal Affairs Council, and do you ever line up where the money's going, for whom, for what, with what data base and evaluation and outcomes accountability? Just trying to get some sense of money coordination if there's not data coordination.
So that's a very good question. Would that everything were as orderly as it would be if you were to draw it out on paper? I think some of our activities have evolved over time. with a clear measure towards tracking how we're spending our money towards different populations. However, we also have funding streams that are targeted towards specific interventions, and sometimes they overlap with each other. So we do try to coordinate across the tribal activities, and in our, I believe we've done some reorganizing at the HRSA IOA level. I believe it's now located in our Office of Intergovernmental and External Affairs, which is where our tribal activities are sort of located. If that's not correct, we'll get you the name. It was in a different office before. But that was the office that was trying to make sure that tribal activities that we're focusing on, not only tribal, but we're focusing on the American Indian, Native Alaskan population, were being thought about deliberately. So as we have a health center program, we don't have a set aside that says, okay, that's going to this and this is going to that, because it does beg the question of, if that's the case, why is it not in Indian Health Services sometimes versus in these other programs? And I think we try very hard not to be territorial in that sort of way, but there are funds that are provided to IHS to do IHS activities. And then there are funds where we have the Healthy Start program, and we are expected to serve the nation. And so in serving the nation, we try to make sure that we are covering rural, we are covering border when border has been called out as a specific initiative, urban, tribal, Hispanic organizations, to jurisdictions. And so there are these multiple overlays trying to count. Our tribal consultation program at the HRSA level is relatively new, only in the last couple of years. We had been doing this as a part of the larger departmental tribal consultation program. So I think we're still working out some of the activities about what are the structures that we're putting in place. Are we counting dollars to match with the various strategies? And I'm making notes as we're having these conversations about recommendations that we can provide. But that's a little bit of the context here. And maybe one of the things that we would do that I can pursue is having our tribal affairs folks be a part of future meetings as we're having these conversations. I know one of our presenters is going to be with us from OPAE, our Office of Policy for the agency. So that's the HRSA response. I don't know, Charlene, if you want to jump in and talk about your approach to this overlapping discussion and priorities.
Actually, Lee, I think you framed it very well. It's similar for us at CDC. We do have an Office of Tribal Affairs that I can provide a link to for further discussion. They handle our tribal consultations, similar to what Lee described for HRSA. And similarly, we have those funded line items, and we try to be strategic with our different lines to target some activities to support work with American Indians and Alaska Natives.
Well, it's very helpful. It kind of is pulling back the curtain of the Wizard of Oz. So thank you for allowing all of us to hear that your efforts are there. And it's very similar in a mirror way to Dr. Pattaralau's new position of trying to coordinate MCH within IHS. How are we trying to coordinate tribal health outcomes for women, children, families, and fathers across federal government, and or at least within HHS? And there's no analogous person or point of accountability that exists that I can hear at the level of the secretary. And I was thinking back about the recommendations, Janelle, you put it out, that if you want to, and I'm going to cite that just for a second, but in the healthcare chapter, or at least in the Broken Promises report, there was a statement that said, just relative to data, accurate data are necessary. And it says, Congress should provide funding to establish an interagency work group to share systems, data, methodologies so that we can have an accurate and disaggregated data on populations. And so the idea that there is an interagency working group, you've got a counselor here, you've got an office there, but there's no nexus for the population that we are passionately focusing on, which is women of child or people of childbearing age, infants, families, and fathers. And so there's an opportunity here that we could be a stimulus for that kind of coordination around something specific to start if it does not exist, and you're telling me it does not exist.
Well, I think that just to build off of this, to take it a step further, the area where we're really trying to make a difference, at least at the program level for me and our division, is to have these discussions before we're making the awards, as opposed to doing the counting after the awards are issued. So that we're saying, okay, if our intention is to engage with tribal communities for Healthy Start or in maternal health innovations, how do we engage with IHS? How do we engage with the organizations that might be applying for these funds, so that we know what are the things that they can and can't do? Can they turn around an application in the time that we're allotting? Do they have the data to be able to demonstrate need? And are we offering up a model or a program that is something, A, that's going to be appealing to them, and 2, going to make a difference for their population? And that's consulting with IHS, that's consulting with these other groups. And so that's what we're trying. Sometimes we're successful, sometimes we're not so successful. But it is the benefit of having gone around this barn a couple times now to see, oh yeah, now we're counting, but maybe as we're competing the next program, we'll take the time to get to that.
That's very helpful. Thank you, Lee.
Thank you, Lee. Comments from anybody who hasn't spoken so far? I mean, any thoughts on the what you've heard so far today, and particularly in the last hour and 15, 20 minutes? Any thoughts?
Is it all right if I just share a little bit about the CMS work related to this?
I would love it. I would love it.
All right. I'm just dropping in the chat that the CMS Office of Minority Health has put out a report on advancing rural maternal health equity. So I'm putting through a link to that. Additionally, we partnered with the Office of Women's Health on a challenge.gov prize competition for postpartum health equity related specifically to Black and American Indian, Alaska Native postpartum people, and related to hypertension follow-up, diabetes follow-up, postpartum depression follow-up, various other postpartum activities. That prize competition is closed, and we are just finalizing the press releases on the winning entries for winning programs that submitted for that. We actually had 62 applications for that. So a lot of great work is being done, and the winners for that will then be allowed to move on to phase 2 of the competition of scaling and spreading their already evidence-based programs that to help that population in the postpartum period. So those are our big things, along with the postpartum care extension, as you're aware, that more and more states are applying to. Additionally, we have our postpartum care affinity groups and our newly launched low risk cesarean delivery learning collaborative, where that affinity group expression of interest is due July 15th. So states can express interest in being a part of that as well. And I know from our postpartum care affinity group, there are states that are focused on the American Indian and Alaska Native populations within their states. As a kind of population of focus for their quality improvement projects related to postpartum care. So it'll be interesting to see if any states choose that same focus for the low risk cesarean delivery affinity group projects as well. So thank you.
All right, thank you, Kristen. Really appreciate it. Sure, you have your hand up.
Thank you so much. I know I've been bold and sharing some just questions and resources in the chat. So thank you for your patience with my communications. I just was wanting to clarify and following up with Dr. Peck's questions about kind of coordinated funding and the note that I included around the funding that did exist that limited competition cooperative agreements through the IHS for the MCH program. I was just wanting to clarify and thought maybe Charlene or others could do that funding actually came through the CDC to the IHS, and it just it was, I just wanted to bring it up and ask about that as a question, because I think I viewed that as an example of funding that was coordinated. It was focused not only on the data and surveillance that Magda mentioned, but also on some of the interventions that have been described today through these regional efforts that were community-based. And so I understand, and I heard the representatives from the Indian Health Service talking about various relationships and transitions in terms of work with tribal epidemiology centers, but just in thinking about that as a model in general for funding and activities that were actually based on the MCHB performance measures. We all had advisory councils. I mean, it was a very comprehensive program. I believe it was 7 years or 5 years that it went on. And I think, as you all know, I feel like we all felt like we were just getting started with some of the activities that we were able to put into place when that funding ended. So I just wanted to mention that as a potential model for consideration, even if it isn't limited competition, but just to be considered. And I wasn't sure if I was correct that those funds to IHS were actually from the CDC. So that was a clarifying question too.
Thank you, Shira. All right. We've been busy. We've been very, very busy. We do have a couple of members who joined us. Belinda, would you introduce yourself? You can unmute and...
I'm muted. I'm sorry about that. I am Belinda Pettiford. I'm here in North Carolina, the Department of Health and Human Services, and I'm head of the Women, Infant, and Community Wellness section. So I'm so sorry I missed being with you all earlier. Am I answering the question, Ed, you sent us? I just was looking at it.
Yeah. What will it take?
What will it take? What would it take? If we prioritize and we really listen to our communities and individuals with lived experience in moving this work forward and actually do what they're asking us to do. I think that is near and dear to my heart throughout my whole 35 years of working in public health. But my meeting earlier today was we had been requested by our Legislative Black Caucus of our General Assembly to come and talk about our sickle cell program. So we have learned over the years that we don't go talk by ourselves. We bring people with that are impacted. So we had 5 individuals to come and share their challenges and share their concerns. And, and they talked about, how they're treated in hospitals when they're looking at being drug-seeking individuals and trying to just do basic pain management. And they talked about their quality of life and discrimination and the things that they really need. And they keep telling us that, and we continue not to meet those needs. So what would it take for us to actually do what they're asking us to do? So I think that is what my response will be today, Ed.
Thank you, Belinda. And Paul, glad you could join us. Paul Wise.
Yeah, hi, this is Paul Wise. Driving in the car. I'm on my way to McAllen, Texas. I apologize for not being able to join on video. I really appreciate the presentations and a critical discussion that I've been hearing all morning. It's very important, and I'm glad that it's been put on our agenda. In terms of answering your question, Ed, my feeling would be to give community groups more money to use at their discretion, to allow them to take more risk to not be so risk averse or always trying to please the funders' priorities and have more power to use more funding for their own purposes. So thank you.
Right. And thank you, Paul. And I'm not sure if you're going to be with us tomorrow or not, because I know you're doing a lot of stuff, but I know that you're going off of the committee. And please accept my thanks for all of the work that you've done, for the leadership that you've given, both for this committee and what you've done over the years. You and I have sort of worked in parallel, at least for 45, 50 years. And your voice in maternal and child health has been very powerful, and it continues to be very powerful. So I hope that we will continue to be partners in this effort for a long, long time. So thank you for all your work, and God bless.
Thank you, Ed. Thanks for your leadership. And it's been a privilege to participate and learn from the other members and the others that have joined us over the years. So thank you all.
Thanks, Paul.
All right, now we're to the point where we're going to do some breakout sessions, the first breakout session, and we are going to look at the recommendations that we put together. So as I said at the beginning, these recommendations, there's a lot of them. And they're sort of like spaghetti thrown against the wall, and some of them will stick, some of them don't need to stick, some of them need to be highlighted a little bit differently, but they've come from the work that we've done over the last year. They've come from the reports that have been written by a variety of groups, and I've broken them down so that we can look at them from two angles. This first time is going to be looking at them from the work through the lens of our work groups. We are our Data and Research to Action work group, or DRAW, from our Health Equity work group, and our Quality and Access to Care work group, because there are components of each of those, the components of those recommendations in each of those categories. So what we're going to do, and I've asked the leads of those committees or those work groups to facilitate the conversation, and I had some questions in the document. Do these recommendations address the most pertinent issues? Are they lacking anything? Do we need some other issues addressed? Are some of them too general or irrelevant? Should some be thrown out? Should we combine some of them? Should they be reframed as expectations and just make an assumption like what we did previously? We assume that, and as a sort of a given, as opposed to having it a recommendation. And then what background information should we need? And then what other questions do we need to know before we can finalize those? So those are general questions for both this session when we're looking at it from the lens of the work group, and then tomorrow the same questions when you're looking at it from the lens of a specific issue. Just like what Magda was talking about, there's a general view, and then there's the sort of overall view, and then there's the sort of the program view. So that's what we're going to do. So I'm going to assume that we will break up fairly equally into these committees, but I'm not sure how best to do that. I can leave it up to you to choose which one to go to. Otherwise, I could assign, but that's going to take too much time. So I'm going to trust that when we give the three work groups, you're going to choose the one that most appropriate for your input, and it's going to be equal. But also, I'm hoping that we've got several members, got 7 or 8 members who are going to be leaving SACIMM, and for 2 of the work groups, the leaders of those work groups are going to be leaving at the end of September, this committee. So we're looking, at least for the remainder of this year, somebody to lead the charge in those areas. So I'm hoping that some of you will say, yeah, I could take the lead in data and action, research and action, or I could take the lead in health equity. Steve, I'm hoping will continue on with the quality and access to care. But so be thinking about taking on that leadership role in this work group, which will continue through the end of this year. After that, I will then leave it up to the next chair to decide whether or not they want to continue these work groups, because it'll be off my hands at that point in time. So Emma, are you going to break us out?
Yes, so everyone, the link is on the screen as well as in the chat. When you go to that page, it will have day 1 and it will list all 3 Zoom breakout rooms. Please click the link to the Zoom room that you wish to attend, and this will be a traditional Zoom meeting. This webinar will remain open, so once you are done in your individual breakout session, you can come back to this main link, and then we'll be rejoining in about an hour.
All right, so it's now 3:30 Eastern Daylight Time, and we'll come back at about 4:30. So you got an hour's worth of work. So we'll see you back in an hour.
Me now?
I can hear you. I can hear you.
Thank you. I've had some more technical difficulties, but I want you to know that the data group was fabulous just to proceed on while I was offline. Kudos to every one of them.
And I think we're getting people back here. So we have, let me just look here. Yeah, Steve's back and Janelle's back and Belinda's back and Magda's back. So at least we got the leads from each of those. And Ken Harris commented on my tie.
Bow tie.
My bow tie. I have to admit, this was a gift to me from one of my favorite people, reflecting its beaded work from American Indian community. And it's a wonderful tie. I can't wait to wear it in September when I are actually on tribal land. All right. I don't know about the rest of you, but I'm getting tired, but I think I can last another half hour and then we'll get a good night's sleep. So why don't we just briefly kind of give me an update on what happened in your breakout groups? Because what I'm hoping from all of this, sort of get a sense, I want each of the leads from those groups to kind of, they'll give an oral report, but get back to me whatever kind of edits they have so that I can consolidate them. And same thing with the group tomorrow, get whatever edits you have, get them back to me and I'll consolidate those into a new set of recommendations. And then we'll go from there. So it's these two groups, two breakout groups looking at these recommendations from a couple of different angles, getting whatever edits, whatever clarification, whatever else we need. Then I'll try to get it back into another master document. And then we'll start working from that right after this meeting is done. And I'll tell you about that in just a little bit. So let's start with room number one, Health Equity Work Group.
So we had a wonderful discussion in the Health Equity Work Group. Lots of good feedback. Let's see, we'll try to go in order. I think one of the key recommendations, first of all, they thought the recommendations were very comprehensive. People did a very good job, all of us working together. I think one of the critical pieces that came out in our group is we really feel like we need to put in writing, we've got to say that how important it is to listen to people with lived experience, and how we can elevate that in every area that we can. And we even talked about, at the beginning of the recommendations, if possible, to have a link for the secretary to listen to some of the voices of people with lived experience, so have it like in the opening, whether it's clicking on the link to the Hear Her campaign or the voices of some of the recordings from other people or any that we can share. But we think it's important, but we also think it's so important that it needs to be integrated into all of the work we're doing around infant and maternal mortality. So to us, that was kind of like an overarching area that we really feel very strongly about, and making sure that that is integrated. I think on the recommendation side, a couple of additional recommendations were suggested. One was around, we need a recommendation on accountability. And so we have some language there that we pulled from the Broken Promises report of 2018, because we really don't have throughout the document accountability areas. So we did come up with some language for that. We also felt like it needed to be some recommendations in there around ensuring that there's a way to be engaged with policymakers, whether these are governors, mayors, Congress, the people that control the resources. And so that they can have we can do a better job of making sure they understand the impact of what they're funding on the outcomes. And so we felt like that was an important piece. I think linking back to listening to people, we had a conversation, especially under the SID area around, we really need to get a better historical, listening to people who have the history, the experience as to why the numbers are so high. Have they always been high? It seems like they're getting higher versus going in a different direction. Is that a reporting issue? Is that an issue that something has changed? Have they moved away from maybe a traditional practice and moved from, into another practice that may not be as impacting them as positively in some areas? We did have a couple of kind of other things, and I'll send this to you in a track changes. Ed, did we just lose Ed, or did I just lose Ed off of my screen? Am I the only one missing Ed? No one else can see Ed either. Okay, well, we'll just keep talking because it's being recorded. So we did talk about, we wanted to change substance abuse to substance use because we felt like that was a better language to use. And we really spent a good amount of time talking about the importance of valuing traditional Native knowledge systems and providing services, designing programs, policies, whatever it is, especially in working with Native populations. So we think that this is an important piece that should definitely be included in here. And I think those were the main areas. I have some more notes and we'll send them over, but I don't know if there's anyone on the committee that wants to elevate any specific area, but we did have really good discussions. Anyone want to jump in and add something else while we get Ed back?
No, I'm just going to say thank you to Belinda and to the people who joined the Health Equity
Wonderful
Work Group. I was also fielding another meeting at the same time, so it was wonderful to have this work move forward and have a lot of perspectives on what should be changed. Thank you.
Yeah, as we started trying to prioritize things, I think what we put at the top of the list, we know funding is needed. It's impacting so many different areas of these recommendations. So we thought funding was a priority, but we also thought the pipeline as part of the workforce development should be one of those areas that we pull out as a priority as well.
Mm-hmm. All right. Well, I guess maybe in Ed's, he'll still be coming back, but group number 2, quality and access. We had a good discussion as well. I think it was really beneficial to have Sharonda Thompson's involvement in that. She brings a unique and very important perspective. We discussed, I think there are 24 recommendations under quality and access, and just a couple of high points, and I'll send Ed the rest too. But there was a real focus as well on personal kinds of relationships, because when moms are just sort of handed a clipboard with, fill this out or fill this tablet out, it's really important to be able to get direct one-on-one assistance in navigating the system in a culturally appropriate manner. So I think that's going to be a priority. There was a mention as well of the mental health issue, not just for mothers, also for infant and early childhood interventions. I mean, especially after what happened in Uvalde, there are some kinds of identifications of really troubled situations. Sharonda also brought up the point that partners, husband, fathers, partners of any type really need to be involved in the assessment of those kinds of things. We have a number 12 is a recommendation that was this comprehensive thing that I think is a new HHS program that was some kind of a residential comprehensive situation, which we're just going to get more information about. There was also a mention of telemedicine and how we all believe in the wonders of it, but there are many communities that either don't have broadband access or really reliable wireless access, or they don't have, the tablet, the phone, the laptop that would be able to allow them to use that. And then second to last, one of the members of our group pointed out that there was a mention in one of the recommendations of the word interventions. So interventions to intervene in a cultural situation, and we'll strike that. Interventions will be changed to some other appropriate word. And then we did have a presentation at the end by Kendra Wyatt regarding some of the issues related to health information technology and the fact that interoperability is not working well at all. And there's a whole variety of ways that needs to improve interoperability, and that patients can own their records and kind of take them with them to get what the best care that they need. But for sure, to change the way the system works. The system is working right now, it seems like, more for the overall industrial medical system than it is for patients. And so we'll put together a recommendation in that regard. So take it away, Magda.
I did get a note from Ed, who, like myself, was booted off, and so technology will always get in the way, and we just keep on moving forward, which is what happened in our breakout group when I was booted off in the middle of it. So allow me to thank the individuals, the close to a dozen folks who joined us. And the way we proceeded was to first harvest what we had heard in the prior presentations on day one that we wanted to make sure was brought into our discussions about the data and research to action recommendations. So we just wanted to make sure we didn't go right to the recommendations without taking into consideration what we had heard, learned, been surprised of, have questions about, that can inform the discussion. And I will forward those on to Ed as well with Emma's help. The second broad brush that we addressed had to do with the recognition that language matters. Intervention is one word that we may want to be thoughtful about, and the nuance of language. And we just want to assure that we're being intentional with the language that we use in what we write in recommendations. Towards that end, an example of that is in the second data recommendation around First Nations involvement and participation should be part of. And the language suggested is, where is the leadership? Should lead what is happening. So be thoughtful about what roles we are relegating folk to that might perpetuate some of the structural hierarchy and history of oppression. So language matters. We also heard that there's questions about what language should we use, and folks are hesitant to not want to in any way offend. And the humility, the cultural humility that we bring. So a suggestion came, could there be a clarification of terms, an education of terms in the preamble, if you will, a glossary that allows us to educate while we are informing the secretary as our primary audience. Other audiences will read this. And so the more that we can link to glossaries and information about what language we can use around First Nations, First Peoples, sovereignty, compact, contract, things that we're learning, we want to pass on the learning. So that's some broad brush work to do. We did a three-part analysis to begin with. What do we want to assure we would elevate up of the 15 that we were considering? What may be some gaps that is not yet addressed at all? And the third had to do with what would we want to clarify and sharpen? And I will not take the time to go in the detail of those now, but know that that's the work that we brought to our section. If there was one thought that I would like to end with, which echoes our other two breakout groups and our working groups, it has to do with the second. This notion about individual, community, collective, first-person voice, the power of the qualitative data, the storytelling, and listening to people was also echoed in the data group as well. We did put out a recommendation when we first started in our ACIMM cohort about the data should be considered qualitative and quantitative in its value, and that the first person voices of people and their stories are essential to hear and listen and integrate and follow. So the recommendation around how do we bring those voices forward appears in recommendation number 2, as well as in other recommendations that we have that we will look at. And I guess if there's a final, there's so much muddled, disconnected, fragmented data out there that don't talk to each other. And the more that we can harmonize, standardize, make them interoperable, let them talk to each other to tell the full story, we can see that that would strengthen our capacity to inform program policies and practices going forward. More will be written up, more will be submitted to Ed, and I'm wondering, is Ed back on board at this time?
I am back. I heard
great.
you, and I heard the end of Steve. Sorry, I somehow got booted off, and it took me a while to navigate back.
Not a problem. And I just want to say I want to lead back with a thanks to Emma for keeping notes. Thanks to Marie and Joy and others for kicking in when I got booted off. And I just want to pause for a moment to see if there's anything that any from that breakout would like to add that didn't get the emphasis in my presentation. So I'm just going to take a pause, Ed, and see if there's anything else we want to hear.
I wasn't in your breakout group, but I did want to say something about the importance of how things are said and how that can make a person feel or respond. I know we're focusing on infant mortality, but I've always in my own brain switched it. Instead of focusing on infant mortality, I'm focusing on infant vitality. What can I do to make their lives more vital and increase that?
I want to thank you for raising your voice, and I want to hear more of it. And you're always part of the data group, even if you didn't come to that breakout. So more to do together. Thank you.
All right, well, thank you all for your work. And I cut out just as Belinda was talking about using other mechanisms of getting information out. And it reminds me, there's something called photo voice where, people use video and we've traditionally, over the time that we've been in SACIMM, we've said, let's focus on qualitative and quantitative data. Let's focus on different ways of looking at it. I think we should really think about it. It tweaks in my mind, how else can we transmit this information to the secretary? Does it have to be in a letter? Does it have to be in a written report? I don't know, but it just struck me. Let's be a little creative and see what we can do. I don't know what kind of resources we have to do some of those things, but at least it'll tweak my brain to think a little bit about that. So I do wish that everybody can glean all your thoughts, put them down in writing, and get them to me. We can do that at the end of the meeting, and the next breakout group tomorrow will do the same thing. But so let me tell you how I plan on moving forward with all of this. At the end of the meeting, I will be forming 4 task groups to help us finalize our recommendations. And they're going to focus on 4 things that I think need a little bit more work to be really totally clarified. One is the Indian Health Service. One is data, because their data are involved in everything that we do. A collection of violence, incarceration, substance abuse, that kind of category. And then the care delivery and workforce. So 4 different sort of little task groups that I think I'm hoping will meet once or twice to try to clarify and hone all of these recommendations. And so I would like to have 1 committee member from our recently appointed members and 1 from our departing group lead these work groups. And then other members of these groups would consist of SACIMM members, ex officio members, and members of our existing 3 work groups. And from my one-on-one interviews with each of you, I have some idea, and from what I've heard today, about who should lead and be on those task groups. But I would like actually you to chime in what your preference would be. So think about which one of these things you would like to be on: the Indian Health Service group, the data group, violence, incarceration, and substance abuse group, or the care and delivery work group. And SIDS and SUID, I think will be part of the discussion of both the data group and the care delivery group, because that's one of the issues that we haven't identified. And so think about that, which one you would like to be on, and then send me an email before tomorrow so that I can sort of see who we could put on those groups. And I think that'll help us to, with these little work groups, finalize those documents so we can get them ready. And I will put together then a little timeline, because I would like to get this work done by the middle of August, actually, because then I would like to get out our recommendations out to others who can critique them, sort of give outside expert review. So again, then we can clarify before we can finalize them in September, and then have actually talked about when we have our meeting in September. So tonight, think about where you'd like to spend a couple of one meeting or two meetings on Indian Health Service or data, violence, incarceration, substance abuse, that kind of category of the sort of catch-all category, and then the care delivery and workforce group, and then send me an email. And, you know, then it sort of gets to the point of that I raised the question, you know, what it'll take, what will it take to get these recommendations finalized? As I said in my introduction, it'll take the involvement and commitment and prioritization of every member of this committee to make that happen. So I'm hoping that we can do that. So with that, any comments that folks have before we sign off for today and meet you back here at noon Eastern Daylight Time? Get a little extra hour in the morning. Any comments before we leave?
And can I ask Anne or anyone from HRSA, just what is the turnaround time in terms of the typed up notes for today and tomorrow?
So we are currently typing up all of our notes that we took from the meeting and briefly reviewing them. And I will send them out as soon as our team is done. So hopefully by about 5:30, you should have the notes from the meetings.
Thank you.
And then it usually takes a little bit longer to process the recording. But once we get recordings or transcripts, we can also forward that to you if you find that useful.
Will you give us a different link for tomorrow? I think today we're the same link as today.
Yes, so tomorrow will be a new link. If you are a panelist, so anyone who's speaking right now, you will get a new link in the morning. I can also will resend that right before the work groups break. So the link will be again right at the top of your email. And if you are a public member, you will also receive an email from me tomorrow with the link for tomorrow as well.
If you're registered. Right. I want to thank and just to echo what Charlene said, this has been a very inspiring and provocative day. So just take a breath with gratitude for all the work that brought us to this moment, and to seize this moment as a time to make pivotal change. So thank you, Ed. Thank you, Janelle. Thank you to all of the speakers. And thanks to all of the SACIMM members. I just want to add one last thing, Ed, and that is, I hope no one holds back. Just because you're a new SACIMM member or you feel like you might be late to the game, you are our secret weapon to make sure that, and you are magical powers, because if it doesn't make sense to you, it doesn't make sense. So we are all of equal footing going forward, and we hope to all of us that it do much better work together. So thanks to all that just jumped right in and made things happen.
All right. So, and those of you who know me, I like history. And today, this is a good piece of Wisconsin history where I came from. One of the senators in Wisconsin was Robert Fighting Bob La Follette, very progressive. He ran for president, was the governor, really created Wisconsin to be a very progressive state. And he pushed for women's rights, voting rights, for minimum wage, for workers' compensation, for a whole variety of things. But he said, this quote that I love, there was never a better time to work for social justice than right now. And I think that was true back in the 20s when he made that statement. It's true right now. And I thank you all for being partners in that work for social justice. So for Robert Fighting Bob La Follette and his birthday, happy birthday, Bob. And we'll continue fighting for social justice with this group and with every other group that we work with. So see you tomorrow.
Thanks so much.